Welcome, everyone. My name is Richard Shilsky. I'm a member of the National Cancer Policy Forum and chair of the workshop planning committee for this workshop. I'm also an emeritus professor at the University of Chicago and the former executive vice president and chief medical officer at ASCO. On behalf of the National Academies, I'd like to thank you all for attending our virtual workshop on cancer care and cancer research in the context of the COVID-19 pandemic, lessons learned. This workshop is convened by the National Cancer Policy Forum of the National Academies of Sciences, Engineering, and Medicine. The forum brings a continual focus within the National Academies on cancer, addressing policy issues that are relevant to the goal of reducing the cancer burden through basic and translational research, prevention, and by improving the care and outcomes for those diagnosed with cancer. Forum activities inform stakeholders about critical policy issues and identify key opportunities for action. The work of the National Cancer Policy Forum would not be possible without the generous support of our sponsors listed here. We're very grateful for their support. And we initiated the workshop planning as the COVID-19 pandemic began to slowly recede in the United States. Yet, as we're all aware, the pandemic is likely to have long-lasting consequences, including on the delivery of cancer care and the conduct of clinical cancer research. Our goal for this workshop is to examine the short and long-term responses to the pandemic and consider lessons learned from this experience in order to improve the conduct of cancer clinical trials and the delivery of high-quality and equitable cancer care in the post-pandemic era. Participants will discuss their recommendations to retain and build on the beneficial changes that have occurred, as well as the policy, practice, and research challenges that will need to be overcome in order to spur progress on the delivery of high-quality care and cancer research. Now, of course, this workshop would not be possible without the work of the members of the Workshop Planning Committee. I want to acknowledge and thank them for their hard work. I deeply appreciate the many hours they dedicated to develop the workshop program. Thank you all. It's been a true pleasure to work with all of you on this important workshop. I also want to thank the forum staff, particularly Francis Amankwa, for keeping us on task and managing the countless details necessary for a successful virtual workshop. Now, this workshop is planned across 2 days, today and tomorrow. Today, we'll have the first 3 sessions. Session 1 will examine the immediate changes in cancer care delivery during the COVID-19 pandemic and the impact on patients with cancer. Session 2 will explore the immediate changes in cancer clinical research during the pandemic. And Session 3 will focus on opportunities and constraints of telehealth in cancer care and research. We'll reconvene tomorrow at 11 a.m. Eastern Time for the second portion of the workshop. Tomorrow's sessions will look into the future and will explore lessons learned to inform and guide our next steps to improve the delivery of high quality and equitable cancer care, and to the conduct of cancer clinical research to make clinical trials more equitable, accessible, and efficient. Specifically, Session 4 tomorrow will focus on opportunities to improve the delivery of high-quality cancer care and to promote equitable access to high-quality care in the post-pandemic era. Session 5 will focus on lessons learned to inform and guide our next steps to improve the conduct of cancer clinical research and make clinical trials more accessible to patients and more efficient. We will end the workshop with Session 6, which will be a panel discussion among all the session moderators on collaboration and coordination to improve cancer care and cancer research in the post-pandemic era. Now, I want to remind you that we welcome your involvement in the workshop. In fact, we encourage it. In fact, we need it in order to optimize the output of this workshop. Please use the chat box located below the workshop webcast to ask questions or make comments of the speakers and moderators. We ask that you please include your name and affiliation. You're also welcome to tweet about the workshop using the hashtag shown on the slide. And after the workshop, proceedings will be published by the National Academies Press. Archived presentations and videos from the workshop will also be available on the website. So without further ado, let's move on to session 1. I'll now turn it over to Drs. Nancy Davidson and Larry Shulman to begin the first session on cancer care delivery during the COVID-19 pandemic and its impact on patients with cancer.
Good morning. I have the opportunity with Larry Shulman to co-moderate this first session, and I'm delighted to welcome you to this session. Today, our goal is to actually think back to where we were about 18 months ago. So we want you to think about the beginning of the pandemic and use that as an opportunity to review the impact of the pandemic on patients with cancer and to examine the changes to cancer care delivery in the immediate aftermath as we were going into those first months. So in order for us to do that, we have some really thoughtful speakers on the panel to guide us today. First, we're going to have a session keynote address from Robert Wynn, who's the director of the Virginia Commonwealth University Massey Cancer Center. We'll next hear from Shelly Fuldnaso from the National Coalition of Cancer Survivorship. Our third speaker is by co-moderator Larry Shulman, who will be from the University of Pennsylvania. Following Dr. Shulman will be Dr. Randall Oyer. He's the medical director of the Ann B. Barsinger Cancer Institute at Penn Medicine Lancaster General Hospital and an immediate past president of the Association of Community Cancer Centers. Next, Steve Pergam, medical director of infection prevention at the Seattle Cancer Care Alliance and associate professor at Fred Hutchinson Cancer Research Center and the University of Washington. Karen Knutson, the new Chief Executive Officer of the American Cancer Society, Inc. and the American Cancer Society Cancer Action Network will speak next, and she'll actually speak about her experience when she was the leader at Jefferson at the Chemo Cancer Center in Philadelphia. And finally, our last speaker is Laura Strawbridge, who is the director of the Division of Ambulatory Payment Models in the Patient Care Models Group at the Center for Medicare and Medicaid Innovation. Now, there are biographies for all of these individuals on the workshop website if you want to take a look at them. And again, I want to provide a review of how the session was going to go. All of these presentations have been pre-recorded, and so we're going to play them consecutively. After the last presentation, we'll be in a live panel discussion, which will include all of the speakers in the session. As Dr. Shilsky said, we really encourage your involvement in the workshop, and so please use the chat box on our website to ask questions. So with that introduction, let's move into session 1. Thank you.
I want to thank you all for joining us to really this important conversation. This has conversation for me, COVID trust and cancer and the impact that it has throughout this entire continuum is really an important one. And two things have come out of this for me. One, the limitations of miracles, even scientific miracles. And two, that I think we're going to have to, at the end of the day, COVID's made me realize that in addition to all the miracle drugs we have and all the miracle approaches and all the big data, we're going to have to get back to basic blocking and tackling and figuring that communication and the ability to effectively communicate to anyone from our academic institutions to the factories that they work in to the farms that folks work on. We need to be more effective at adding another tool in helping people stay healthy by communicating much more effectively than I think we have in the past. I have these are the financial disclosures that I need to make. I will not be discussing anything off-label use or investigational use in my presentation now or ever. But I want to take us all back to February, March of 2020. We were all discombobulated. We were all on our heels. We were all trying to figure out what was this viral COVID-19 thing doing. We understood that not only was it here, but that it was growing. The interesting thing is we were all trying to figure out, it was making people sick, putting people in hospitals. How do we test for it? Or were there antibodies for it? Were there treatments for it? We were going through all this rigmarole because we were, for the most part, not really all that prepared. One thing we did know for sure, though, that was an early indicator of what was to come is that there were certainly populations of people, communities of people that were disproportionately disadvantaged and having more cases of COVID and worse outcomes. The interesting thing about that is that we do what we typically do in medicine and science. We started unlocking and trying to investigate all the biological reasons why, for example, African-American may be doing, and African-American communities may be doing less well than others. We looked at the impact of polymorphisms, and we looked at ACE and TMPRSS2, and we looked up and down and found that in general, the evidence of genetic or immune predisposition, the biological associations of race and ethnicity were not really associated with being the main drivers of COVID death disparities. But interestingly enough, the educational attainment, whether one held medical insurance or if one had higher incomes, certainly were predictive of a better outcome and were predictive of, if you got COVID, actually ultimately surviving it. On top of this pandemic, this COVID, we had the reawakening for many in the country of what's been here for a very long time. Difficult issues to talk about nonetheless, but during this period of COVID, it enhanced and augmented the conversation of the racial unrest that we had in this country. Not only racial, but class. I'm reminded about the 8 minutes, 46 seconds that George Floyd's life was literally snuffed out before the country. And I think that we were not only on our heels trying to deal with this new viral pneumonia and trying to figure it out and trying to understand the biology and the consequence of it, but we were face to face with the fact that we could no longer not look in the mirror and understand that we were dealing with the racial unrest, social structures, and other things that were contributing also to this disease. It didn't help that as scientists and health professionals, we too actually had blind spots and unfortunately were revealed during this very moment. I think that that awakening, that the health profession and scientists also had blind spots, was not an overall negative, but a positive, because it gave many of us a time to pause and reflect about the work that was ahead of us. Now listen, many of us have talked about social determinants of health. That has become an incredible sort of a presence now, particularly as we talk about moving forward through COVID. But let it be known in 1899 that W.E.B. Du Bois, a wonderful social scientist ahead of his time, wrote the definitive papers called the Philadelphia Papers, describing exactly these inequities that existed here, the structures that were attached to those inequities. Interestingly enough, in his lifetime, he too experienced a pandemic, a respiratory pandemic, that being the Spanish flu pandemic of 1918 through 1920-21. But he also, during that same time period of a pandemic, similar to us, had racial unrest. It's called the Red Summer of 1919, but many of you remember what happened in Tulsa, Oklahoma, Elaine, Arkansas, and many places throughout the United States where African Americans were not only evicted from their homes, but literally slaughtered in the streets. I say all this to tell you that as I now move through COVID, and we're thinking about COVID and its impact, particularly on our cancer patients and other things like that, it has become clear that the social determinants of health that exist now cannot be separated from the history that created some of these structures and the policies. Policies like redlining from the 1930s, which definitely had communities segregated by race and just buying homes. But despite those redlining principles, there were robust, incredible communities that thrived. The Jackson wards of Richmond, the Wall Streets in Tulsa. But all of those robust communities that were able to thrive, even despite segregation, could not actually stand up to the challenge of the urban renewal process, or what's called slum clearance of the 1950s, 60s, and 70s, which in some cases were the death blows and certainly crippled many of these African-American communities, setting the stage for what we would actually recognize in COVID became incredibly important. It wasn't that there was any issues with biology, so some mild issues here and there. It was the structure that people were placed in that we finally recognized actually predisposed people to comorbid diseases that ultimately led to their having more rates and poorer outcomes. So the miracle, and it was a miracle. Warp speed, many of the other things of getting an mRNA vaccine, not just developed, but getting it out to the masses was nothing short of a miracle. But we were amazed that some of us were scratching our heads why people didn't want the miracles. Why people were hesitant or even downright refusing. This is the limitation. These are the limits of the miracles of science. We also recognize that during this issue that communication and trust became essential. And so for me, Bishop Gerald Glenn was an example of how we as a health field, as scientists, as people who really want to actually make people better, miss the mark in our ability to be able to communicate effectively and clearly to Bishop Gerald Glenn, who is one of the more powerful leaders here, African-American leaders, faith-based leaders in Virginia, who said God is larger than COVID-19, but unfortunately he and people of his congregation as well as his family succumbed to COVID. I'm sure had he had better information, I'm sure had he had more trust in our system, I'm sure if we were able to think not only about the creation of the new molecules and the next miracle drugs, but the next best effective communication as a health tool, he may have made a different decision. Recognizing that, COVID gave us the opportunity to do things differently. One example of that was to understand that while we were in our laboratories trying to figure out tests, while we were in our laboratories trying to figure out therapies, while we were trying to figure out in our clinics, trying to take care of these inpatients and ICUs and everyone better, we were also trying to figure out how we could communicate better. Join as a partnership with the community, bringing science closer to the community so we may thereby benefit the community better. We did a small experiment here in Richmond, in Virginia, of having Pastor Hargrave from the storied 5th Street Baptist Church, Redeemed Mercer Hayes, who is a giant and a loud voice within Virginia, partnering up with something called Facts and Faith Friday, which essentially was a commitment from us to always be there every Friday to bring information both from internal experts and external experts, just like Fauci, so that we would not only give them information to help them tell things to their congregation, but to their community. Because when there was mistrust and distrust of both doctors and scientists, there was very much trust within our communities of not just faith-based leaders, they're beyond that, they're trusted leaders within the community. And being able to get the message out of getting COVID, of setting up things within their churches because people didn't want to actually go other places, I think helped a little bit. And in fact, they're closing churches and not having their regular services probably saved thousands of lives. So I want to just reiterate that while there's a lot to talk about in the context of what we didn't do right during COVID, I think what we've come to is a wonderful opportunity of what happens when we communicate with one another differently, when we partner with one another differently, when we partner with community differently, and recognizing that there's even limitations to scientific miracles. It's within that spirit that we open up this conference, this workshop, and hope that you enjoy the rest of this meeting. Thank you.
Hi, I'm Shelly Fuldnaso, CEO of the National Coalition for Cancer Survivorship. NCCS is a patient advocacy organization based in the Washington, D.C. area, and we advocate for quality cancer care for everyone touched by cancer. I want to thank the organizers for inviting me to join you today. I want to share some results of two different data collection efforts to get the perspectives of cancer patients and cancer survivors. So first, I'm going to talk a little bit about a telehealth project that we did really early in the pandemic. We wanted to hear from cancer patients and cancer survivors as telehealth was exploding in usage, what was working for them, what wasn't, what kind of support that they needed. So we recruited a diverse group of 29 cancer patients and survivors to participate in focus groups conducted in May and June of 2020. We also surveyed providers about their feedback and their use of telehealth. And from that, we created a patient tip sheet on how to prepare for telehealth visits. We created a resource for providers on how to address some of the patient barriers and increase the effectiveness of telehealth visits, and then some policy recommendations. And these are all available on our website at canceradvocacy.org/telehealth. But just from the high level feedback from the focus group participants, and just remembering this was early in the pandemic, they reported some pros and cons about their telehealth visits, and some of which are contradictory and reflect the divergence of viewpoints. So the pros were the safety during the pandemic, convenience and lower costs associated with travel and time away from work and family, reduced barriers for patients with mobility limits or cognitive deficits, the ability to record visits and include family and caregivers. And then some patients said that they would be more comfortable and less anxious at home. This was one area where we had some divergence. Some of the focus group participants said that their providers seemed to have more time and fewer distractions as a pro of telehealth visits. But also on the con side, some said that their providers felt like their providers had less time and more distractions. And again, this is early in the pandemic, so I think probably some of those challenges were smoothed out over time. But some of the other cons that we heard from patients were the technology barriers, anxiety using telehealth, learning curves for both patients and providers, privacy concerned, reduced feelings of connection and emotional support and increased isolation, and then limited access to the cancer care team. They were happy to be able to talk to their doctors, but wanted to be able to talk to the oncology nurses or the social workers as well, and didn't feel like they had as much access to them via telehealth. So then we also conducted, as we do an annual state of survivorship survey, and it's a national survey of cancer patients and survivors. We started with in-depth interviews, 16 interviews in March of 2021, a mix of stage 4 metastatic patients and patients with low socioeconomic status. And it was a mix of race, ethnicity, and cancer types. Then we did a nationwide survey of about 1,100 cancer survivors. This was fielded in May. And we set quotas to make sure that the sample was representative by a number of different measures to make sure it really represented the cancer population in the United States. We also surveyed NCCS connected patients and survivors, about 500 who came through. They learned about the survey through NCCS, and there's some differences between those two survey populations. So the survey was wide ranging. We covered a lot of topics. We're going to be launching the full results in September, and we'll talk then about some of the mindset, cost of cancer, disparities in care, and support systems, and what we learned from patients. But what I'm going to talk today about is just the findings on treatment during COVID. So at a high level, over the last year, most said that the pandemic did not have an impact on their care. About 4 in 10 had a telehealth appointment for a range of reasons, and most rated them as excellent or very good. That said, more prefer in-person appointments in the future. We asked about a variety of types of visits and what they would like to have in the future for those visits. They're most open to telehealth visits for counseling and education, medication management, and sharing of test results. So, we know that there were delays in care, but when we looked at 1,100 people in the sample and 500 in the NCCS sample, the pandemic they reported that the pandemic did not have a huge impact on the quality of their care. More than half had a cancer appointment during the pandemic, and 92% of those still in treatment. When we looked at, was their care better, or the same, or worse? Most said they stayed the same. Only 4% said their care was worse. If you see at the bottom that is the people who were currently in treatment, 14% said better. Their care was better during the pandemic. 74% said the same, and only 7% said worse. We know that there were cancellations and postponements of appointments a little bit higher for people who were in treatment. And we asked about if they were kept waiting or have had difficulty getting medical appointments. Again, relatively low numbers, a little bit higher for the people currently in treatment who are having more appointments than the people who have completed treatment. 4 in 10 had used telehealth services during the pandemic, and this shows the most common types of appointments and then how they rated the appointments. So you can see the areas where they rated the appointments lower were first visits with a healthcare provider, getting a second opinion, and then physical therapy and rehabilitation appointments were lower. Now, granted, in some of these, there were a small number who had second opinions and physical therapy. So these really are considered directional because the sample sizes were small. But you can see that the rates of satisfaction and saying that the appointments were excellent or very good were fairly high for follow-up appointments, regular well visits, sharing test results, medication management, treatment planning, and decision making. And then surgical consults and survivorship appointments were very high at 89%. So let's move on to the next slide. So we asked about which types of appointments going forward would you like to have in person versus preferring telehealth. Most appointments, patients said they prefer in-person visits. There were a few exceptions, and those were counseling and education, medication management, and sharing of test results. Survivorship appointments were closer, still prefer in person, but had still a fair number who would prefer a telehealth visit. Some of the comments we received that things like physical therapy, they definitely preferred in person because it's just challenging to see over a screen what they're trying to do, and they feel like they need to see that in person. With medication management and refills, those are the types of things when you think about the burden on cancer patients of how many visits they have. If there are things like that that can be conducted via telehealth and saving them the time and expense of getting to an appointment, those are our options. But you can see that they still overall prefer most of these visits to be in person. So thank you very much for including me, and I look forward to the discussion.
Hello, everyone. I'm going to spend the next few minutes talking a little bit about some of the approaches that we've used in the U.S. In the early phases of COVID and what the lessons are that I think we've learned from that. I think it's important to think back to March of 2020, a little bit over a year ago, and really what cancer medicine was like. We really had no idea what to expect. We didn't know how to plan or proceed with cancer care, what the needs of the patients were, or their infection risk for patients and staff, or how to manage hospital resources, whether it's testing capacity or ICU capacity, surgical capacity, and so on. And all of us were really learning on the fly, and it was pretty stressful for us and obviously even more stressful for our patients. But major disruptions can also facilitate change in the way that we work. And I have this quote from Albert Einstein at the bottom of the slide: bureaucracy is the death of any achievement. And I think one of our concerns was that there is a lot of bureaucracy in the U.S. healthcare system. There is in the U.S. a spirit of individuality, which I think in many respects is good, that applies for both organizations and individuals, but it's very different in other countries. In Sweden, where there's a single healthcare payer system, a single medical record, care can be coordinated across the country in very seamless ways. And even in places like Rwanda, a place that I also work, it's much more coordinated. But in the U.S., the payers are very fragmented. There are a lot of private payers. There's the government insurance. Medical record information is very fragmented. And professional organizations, frankly, are often non-interactive and sort of do their own thing and go their own way. And in this, in a normal time, whatever that is, this still seemed to work pretty well. But all these things became stressed during the early phases of COVID. In Canada, though, in Ontario, they very quickly got themselves together as a country. You can see that this was published in March 10th in 2020, very early on in the pandemic, about a clinical guide for patients with cancer and how to care for them. And though I'm not going to go into the details of this, they developed a prioritization system, which helped all of us in this country as well and other countries in the world, and how to think about how to care for our patients with limited resources and great strains on the healthcare system. done very, very quickly and was adopted throughout Canada. But we did some good things here in the US as well, I think stimulated by really the stresses of COVID and the pandemic on our healthcare system. As an example of that, I wanted to talk a little bit about managing our breast cancer patients, and clinically I'm a breast cancer medical oncologist. And we were all struggling with how to manage our patients in the face of the limitations I discussed earlier on. And so 5 organizations, the Commission on Cancer, the National Accreditation Program for Breast Centers, the American College of Radiology, the American Society of Breast Surgery, and the National Comprehensive Cancer Network, or NCCN, very, very quickly got together in March of 2020 to try to figure out whether we could develop guidance for our colleagues and our patients throughout the US and how best to manage our patients with breast cancer. And somebody actually kept track of how many emails went back and forth, and there were about 1,700 over the period of a week. But out of that came a manuscript really created within 7 days that was sent to the journals on April 8th, 2020, and accepted for publication on April 10th, 2 days later, which must be a record. That involved 19 authors, of which I was one, from these 5 different organizations. And we came up with a very detailed and lengthy document to help our colleagues and our patients navigate breast cancer care in the US. And it was really quite an amazing experience for me, because these were people who were not used to working together. And then 3 days after it was published, we had a webinar that was hosted by the NAPBC, but supported by the entire breast cancer consortium that I showed you in the previous slide. That webinar was pulled together in 3 days' notice. It was publicized, and we had almost 1,000 attendees at that webinar. And I think that was a reflection of the need for guidance throughout the US. Another example of how we came together was an organization by the acronym CCC19, or the COVID-19 Cancer Consortium. And they rapidly pulled together multiple academic centers, which I'll show you on the next slide. You can see the number of authors in this paper. And within really a month, they were able to obtain over 1,000 patient records, cancer patients who had developed COVID-19, and analyzed those 1,000 patients and came up with the interpretation that among patients with cancer and COVID-19, 30-day all-cause mortality was high and associated with general risk factors as well as risk factors unique to patients with cancer. And this was again a time when we really did not understand the effect of COVID on our cancer patients. And this was incredibly important information published again very rapidly in May of 2020 in the Lancet. And this is really, I'm sure I've left somebody out, but this is a partial list of the academic institutions in the US, in Spain, in Switzerland, and Canada that all came together and very rapidly agreed to pool all of their clinical data so that we could learn more quickly. And this again, I think, it's happened in the past, but it's never happened so quickly and with such really transparency. And I think it was really a tremendous example of what can be done when we need to do things. We at Penn pulled together some advice, again, on the management of lung cancer patients during the pandemic. And though this came out of Penn, and the reason I highlight it is that we rapidly got support from a number of different organizations. And again, this was quickly published in an ASCO journal in May of 2020. The National Comprehensive Cancer Network, or NCCN, also pulled 30 academic centers together in March of 2020. I was part of this task force. We met every Friday at noon throughout the entire spring, and we had very open, transparent sharing of information about how we were managing COVID in our cancer centers, which was, at least to me, extremely helpful, and I think helpful to not only the NCCN cancer centers, but also we published our data, and we held a number of NCCN webinars, also very, very well attended, again, disseminating information very quickly throughout the US. And then when COVID vaccine became available for cancer patients in January of this year, we formed a vaccination advisory committee. It was formed on January 11th, and we worked literally around the clock for 11 days and published our guidance on January 22nd. 11 days later, preliminary recommendations of the NCCN COVID-19 Vaccination Advisory Committee. And we've revised those guidelines now twice, and there's now version 3 that's up on their website. And this was a very large consortium of people, both from within the NCCN and outside the NCCN, including ethicists and others, helping to give guidance about how to manage COVID vaccine in our cancer patients. So the question is now, what can we learn from this and what can we do going forward? Can we preserve some of the collaborations across programs and across professional societies? I hope so. Can we continue to share information freely, transparently, and rapidly, as we did during the early stages of the COVID pandemic? I think with great benefit for all of us providing cancer care. And can we avoid, frankly, the re-ossification of the US healthcare system, particularly in relation to cancer care? So with that, I'm going to stop. But I think going forward, we should just think about what we've learned, what we were able to do when the chips were down, and what we can do going forward. So thank you very much for your attention.
Thank you to Drs. Shilsky, Davidson, and Schulman for asking me to speak on the community oncology voice during COVID-19 pandemic and its impact on patients with cancer. I'm Randall Oyer, the immediate past president of the Association for Community Cancer Centers and the medical director of the Ann Barshinger Cancer Institute in Lancaster, Pennsylvania. Next slide, please. We are a cancer institute that is part of Penn Medicine, University of Pennsylvania Health System. We see 2,700 new cancer cases per year. We are one of 2 community hospitals in our region, and we employ 10 of 14 community medical oncologists. Next slide, please. We immediately identified community oncology public health priorities when the pandemic hit, and the top 3 were to preserve hospital capacity for critically ill cancer patients and others, to create backup for smaller groups in the event that an oncologist from a small practice became ill, to create community standards to provide cancer care across our community, and we identified 5 action steps, which I will address. Next slide, please. Starting with a community oncology COVID-19 collaborative of all oncology practices in town. We sent personal invitations to the lead doctors, nurses, and administrators of all the practices. We set up a weekly conference call to share information, experiences, and approaches, and we created agendas to jointly test strategies, report back, and this actually worked like an informal PDSA cycle. Next slide, please. We moved the ethics of patient-centered care from the background to the foreground with discussions of equity across society. We openly communicated that moral distress may arise when resource constraints impact individual rights and preferences. These were conversations our physicians hadn't been used to having. We explained the public health approach that supports frontline delivery of care to those not accustomed to such considerations. We planned ahead to meet ethical challenges with triage, processes, tools, education, and support. And we clearly transmitted to our teams a framework for the allocation and protection of staff, space, resources, and supplies. Next slide, please. Across our community, we adopted the Penn Medicine principles for cancer care. These have been developed by Dr. Schulman for all of Penn Medicine entities. There are 4 examples here. When possible, the standard of care should be delivered. Priority should be given to patients with potentially curable disease. End-of-life patients should receive necessary care delivered at home via televisits. And the age of the patient, as well as comorbidities, should be taken into consideration. Next slide, please. We made outreach to community partners caring for vulnerable people, including nursing homes, extended care facilities, shared living, and prisons. We developed and communicated policies for accessing care. We communicated directly with medical directors, patients, and families, and we provided home visits and drive-up injections in our parking lot. Next slide. We set up a COVID-19 case discussion conference, and you can think of this as a tumor board with one more factor in addition to cancer stage and comorbidities to take into account, and that is risk of COVID. The purpose was to provide safe and equitable care. We standardized and streamlined case presentations, and a physician other than the treating physician suggested to continue, modify, or stop therapy. 10% of case discussions resulted in modification at the time. 100% of the physician presenters were satisfied with the process and the outcome, and 95% of patients and families were satisfied with the process and outcome. Next slide, please. Switching gears from one community voice to community voices across the U.S., the Association of Community Cancer Centers is a multidisciplinary association of 30,000 plus cancer team members, from clinicians to researchers, hospital executives, administrators, and so on. The ACCC represents 2,100 private practices, hospital-based cancer programs, large healthcare systems, and major academic medical centers across the country. Next slide, please. We set up a community cancer care delivery amid COVID-19 educational initiative. Overall, almost 27,000 care team members reached our educational programs. Live webcasts, we had 2,800 people who watched these. Over 4,000 people listened to our podcasts, and we had a peer forum that had 1,400 members and 24 discussion topics. Next slide, please. There were 10 mini podcasts. You can see the topics starting at 12 o'clock and going clockwise: urban cancer care, telemedicine, biocontainment, personal protection, testing strategies, staff resilience, and so forth. Next slide, please. We had live webcasts from May to July of 2020. There were 764 webcast attendees. Topics you can see on the left: infection control measures, risk stratification for cancer patients during COVID-19, testing strategy, optimizing staffing strategy, and so forth. Next slide, please. These are the results of the webcast: positive impact on clinical practice in the third column, improved knowledge, skills, and strategies. At the bottom, you can see 82% of people agreed with that statement. Next column, ability to provide better treatment and/or care, 74%, and contributions to the team and patient outcomes, 90%. Next slide. Based upon our programs, ACCC members reported the following practice changes: apply the most up-to-date COVID-19 guidelines, update communication and coordination of care, institute or revise infection control procedures, modify treatment and management approaches, focus on shared decision-making, and support informational, emotional, and psychosocial needs. Next slide, please. In summary, community oncology asked, how must we do our part? Top 3 answers: continue to provide high-quality, patient-driven oncology care. Care for the entire community with new partners, shared resources, and shared information. And learn new lessons, contribute to the data, and eliminate disparities. Next slide, please. In closing, I'd like to thank my Lancaster Community Oncology COVID-19 collaborative partners, Penn Medicine, Dr. Lawrence Schulman, Dr. Lee Beamer, ACCC team, and the National Cancer Policy Forum. Thank you.
I'd like to thank everybody for the invitation. I'm Steve Pergam. I'm an associate professor at the Vaccine and Infectious Disease Division at Fred Hutchinson Cancer Research Center, and I'll be talking about integrated care perspective. So there are a lot of challenges that exist within the integrated care system. Cancer care and admissions are usually combined with an inpatient population. We have large transplant and leukemia services, which make up large portions of inpatient care. And plans for a large number of inpatients need to prepare for shifting in that comprehensive care systems. As an example, less ICU beds available for CAR T-cell therapies. We also had to prepare for high-risk patients in high-density outpatient environments. And so this was a complicated process. It was important that we, and Seattle were one of the first to see this. And I got warnings because of already great communication systems that exist, and that's on Twitter. And this was a notice that was put out by someone who was in Hong Kong at the time. And, it was literally 20 days later that we had our first case in Washington. So we had to be preparing, and that early warning sign gave us a heads up that we needed to start getting ourselves ready. I think in general, cancer centers were better prepared, and something that I think we forget is that we're organized and well established to prevent respiratory viruses. We'd had experiences with H1N1. We had developed screening approaches in our locations for rapid testing. We had staff that were well trained and focused on infection prevention. We had policies that limited presentism. We had patients and caregivers that were well educated with community to avoid community exposures. And a lot of them, particularly high-risk patients, were more cautious. And then cancer centers are very well connected through societies and other collaborations, which allowed for early sharing of policies, procedures, and experiences. So as an example of some of the things we did, we had to prioritize who got transplants and CAR T-cell therapy because we knew that we could not overload our inpatient service with high-risk patients. And so this is a paper from my colleague, Masumi Ueda, where we broke down specific groups where we would consider delay and where we would potentially move to delay patients who were going through these procedures as an opportunity to decrease the number of inpatients who would be in our hospital system. We also needed to build capacity for testing off-site. So we had drive-through stations, we had pre-procedure testing, we tested asymptomatic employees off-site. We moved what were conference rooms into clinical care. So those conference rooms became clinical testing sites. And that was really important as we had flexible staff who could play different roles and were willing to step up and do something different. The picture on the top is my research coordinator who became an important aspect of testing for patients. We also had to leverage technology. So we changed to an app-based symptom screening process. And this really helped us to make sure that we did not have people coming in who were symptomatic, who were staff, and to get them tested quickly if they were symptomatic. In terms of communication, we really needed to shift our thinking about how we did this. We really worked towards more communication with patients. And the example I give you is a pre-visit messaging, where through a system, we called patients for review of symptoms pre-appointments, allowed us to identify patients early and send them for testing, limited patients with active symptoms on campus. And then those we knew were positive, we could call them daily to track to see how their symptoms were doing and organize repeat testing or admission to the hospital. And then our social media team and our communications team worked really hard on getting data out to people that was available in places where they could see it and where they were using social media. So our web pages were updated to give constant updates of information. We focused again on caregivers and family through education, but also as we got into the vaccine process, we know that they're more likely to have high-risk exposures, and we can't prevent those exposures necessarily. So we worked on developing good communication to get those caregivers and family members vaccinated and working on a cocoon strategy to protect them. And that really helped because we'd had experience with the influenza vaccine and our approaches to vaccinate family members while they were in clinic. And so that process allowed us to move forward much more quickly in that space. And I think finally, using modeling data to predict our needs was important. So we had models from other groups, which allowed us to plan for possible surges. I mean, the models had weaknesses, but they allowed us for planning worst case scenarios. So we could model out PPE usage and determine needs potentially within the system. It also allowed us to prioritize shifts in care during expected inaccuracies that might also affect our care. So in order to sort of plan around this, having that data, we were able to shift our approaches and decrease our surgical group as an example. There's been so much great work. Our baseline prevention strategies protected patients. We had education that really helped us. We shared protocols and prevention, as has been discussed by others in the US and worldwide. We developed national guidelines quickly. We did studies on shoestring that required people to volunteer their time and support studies. We developed really robust vaccine delivery systems, and we really focused on equity within our systems with our vaccine allocation, which I think was really exciting to see. I would just say, save our notes. What worked? What policies did we save? Where did we make mistakes? What did we hope to we had done in advance? Who stood out as leaders? What extra training do we need within our systems? And what were weaknesses? And what was the best way to communicate was something that we constantly struggled with, both for our staff and our patients, and something that I think we're still trying to improve upon. And I think that's my quick talk, and I'll be looking forward to the discussion afterwards. Thank you very much.
Hello, everyone. I'm Karen Knutson, the Chief Executive Officer of the American Cancer Society and ACS CAN, here to talk to you about lessons learned for COVID and cancer care in a large academic health system. Of note, during COVID and prior, I served as the Executive Vice President of Oncology Services for Jefferson Health and the Enterprise Director of our Sidney Kimmel Cancer Center at Jefferson. Just to socialize you a little to the issues that we faced at Jefferson during COVID, it's informative to know about our catchment area. So the cancer program at Jefferson serves a 7-county catchment area, 4 counties in Pennsylvania, 3 in New Jersey, as shown. This is a highly dense, highly heterogeneous, high cancer incidence population, as shown by the heat map. In total, this is almost 5 million individuals, and if put together would be the 25th largest state in the United States. So, again, a very dense area for us to serve. New cancer cases within Jefferson on any given year are about 10,000 index cases just diagnosed within our system alone. And we distribute care at Jefferson through a 14-hospital system, including 4 SKCC advanced care hubs that we stood up across the 2-state region, which served as areas for us to deliver clinical trials and advanced care throughout the region. It's also of importance to note that we were hit very hard during COVID with the number of inpatients that were COVID positive through our system, resulting in numerous surge plan activation events throughout the course of the pandemic. I just plotted for you here what those peaks looked like, and on any given day in peak 1 and peak 2, we would have more than 650 COVID positive inpatients within our Jefferson Health system. So this posed quite a challenge for the cancer program, and we took advantage of the large academic health system that we had. So I just put some, I think, of the key lessons learned for us by way of the timeline. In the first peak, we had the advantage of putting together a daily incident command across Jefferson Health, but also one for the cancer program, complemented by something that became for us very important, which was alternative means of rapid communication. We used Slack as a HIPAA compliant channel for SKCC leaders every day to connect. And importantly for us, we included an infectious disease specialist as part of that as well. And that proved to be a really critical member of our team. That team was able to then take best evidence happening locally, happening nationally, and convert it over into activity, and to also help shape our policy. So we were, of course, asked by our states and regions to reduce care down to essential care services. The cancer program considered surgical procedures for cancer, including surgeries to rule out cancer, as essential services. So we really did not dial back surgical oncology procedures, which is important to us. We also were able, even in the absence of initial evidence, to successfully negotiate for masking all cancer patients and their caregivers at that time coming in, which is a deep investment for us in PPE as an organization. Cancer patients were called out as being extremely potentially susceptible, and so we took a precautionary measure to mask everyone. Telehealth escalation was also something that gave us an advantage because of our preparation as an academic health system. It was already in use by our cancer program with a requirement of 1 telehealth visit per month per provider. So they were well skilled. We had the technology, and escalation was key. This also allowed us to escalate e-consent and other mechanisms for including trial continuity for patients with any patient that was able to be put on a trial that had potential for curative intent was deemed essential. We also used our communication strategies for greater alignment to community practices. So really in peak one, this is where the bulk of the learning was, and it was that rapid communication channels allowed us to have nimble evidence-based decision-making. It also allowed us to take a breath during the lull, to escalate an opening of new trials that we realized will be very important, to refine our processes, but also to take care of ourselves and partner with our Department of Psychiatry, where we had psychiatrists deployed to each department to provide support for providers and staff. This was really key for us given how hard we were hit. In the second peak, we were rapidly again able to escalate all the mechanisms we put into place to further improve our ability to navigate patients through the complex challenges posed by COVID and really double down on that learning. It also allowed us, as we started to hit that downslope of the second peak, to really push for return to screening initiatives. I wish these had been even more successful, but we were very glad to implement them as early as we did. So in total, I'd say there are 4 lessons learned from us as a large academic health system across 2 states serving a diverse population. The first is to prepare oncology teams by supporting competency in emergent technologies. That previous experience and having previously stood up telehealth prior to the pandemic led to that escalation. We also knew what additional support mechanisms we needed, including social work teams to help bridge the critical digital divide and help our patients, for example, get emails so that they could actually engage in a telehealth visit. The second was to enrich their use of rapid communication platforms for care teams across the geographies. I talked already about the rapid decision-making and real-time comparators of experiences during the crisis. This served as a mechanism for us to report and adjust to regional variances across our system as well. The third is to include key stakeholders in cancer policy decisions. I already talked about infectious disease, but we also capitalized on knowledge from the other cancer centers through AACI that set up also a Slack channel to allow us to compare variances in care delivery as well as in clinical trial activity. And lastly, to develop emergency plans with community stakeholders. So our ability to take in patients from community oncology centers and practices who had staff that were COVID positive and could no longer care for their oncology patients became really key, but also including connectivity in those emergency plans with community advocates is something that we gained a further appreciation for during COVID. So I hope you found this helpful, and I look forward to answering any questions. Thank you.
Good morning, and thank you to the National Cancer Policy Forum for including me in the discussion today. This slide has our standard disclaimers. I'm going to start at kind of broad and high level. CMS established a number of critical flexibilities early in the public health emergency. And while this really isn't my area, I'm just going to cover it briefly as I wanted to flag some key areas, including telehealth, where Medicare provided flexibilities to allow patients to be seen virtually to limit their potential COVID exposure, which of course is critical for immunocompromised patients in cancer care. And we've heard repeatedly throughout the pandemic from oncology practices about the benefits of telehealth waivers for cancer care and an interest in those flexibilities continuing post-pandemic. So please stay tuned for more about telehealth from Dr. Fleischer in session 3 today. CMS also changed policies not only about how patients can receive care, but also from whom and where, and reduced documentation and reporting burdens as well. And overall, the goal has been to try and give flexibilities to allow healthcare providers to focus on keeping patients healthy and safe during the public health emergency. Another broad CMS flexibility that evolved during 2020 was what constitutes hospital care. Initially, CMS announced the Hospital Without Walls program, which provides broad regulatory flexibility that allowed hospitals to provide services in locations beyond their existing walls. And then in November of 2020, as hospital capacity was strained and cases were surging, CMS announced that hospitals could request waivers to give additional flexibility to treat eligible patients in their homes. That includes a relaxation of the requirement for 24/7 nursing. And I do want to point out this builds on previous experience that we at the CMS Innovation Center had in a Healthcare Innovation Award with Mount Sinai. So far in this Hospital Without Walls and now broader hospital at home program, we've had robust participation with more than 140 hospitals requesting waivers as of the end of June of this year. I wanted to flag this one in particular, as well as the telehealth from before, as we've had some stakeholders express interest in a future oncology model incorporating or even focusing on a hospital at home approach. And so we've been watching this experience closely as it evolves in the broader Medicare program. In addition to the broad Medicare flexibilities, CMS established a number of flexibilities for our alternative payment models in June of 2020. And generally, these flexibilities focused on 3 areas: payment, reporting requirements, and model timing. As you see on this slide, we have a number of general principles that informed which flexibilities we gave for each model, including that we wanted to continue our commitment to value-based care and payment while also minimizing risk and reducing burden so that model participants could focus on patient care. So what did we do for the oncology care model, or OCM? In the first column, you can see in payment, we created an option for participants to opt out of risk and determined that we would remove COVID-19 episodes from those who decided to stay in risk. We also made quality, clinical, and other data reporting optional, and we extended the model for 1 year to provide stability. We believe that those changes were necessary based on feedback from oncology practices participating in OCM. They told us about their need to focus on patients and safety and how many of them had to, for example, divert staff that would normally report data to us to other roles in the practice. We also heard about the challenge of managing chemo patients where side effects from their chemotherapy, like fever, may look like COVID. And practices also told us about how, in addition to their treatment volume dropping during the height of the pandemic, their treatment patterns were changing as well. For example, some were delaying the timing of surgery for certain early stage breast cancer patients in favor of starting these patients on hormonal therapy. And these changes could lead to unprecedented cost patterns that may vary regionally and make benchmarking both difficult and risky, both for Medicare and for the participating practices. Other OCM practices requested more time before any new model that we might consider, as OCM was supposed to end midway through this year of 2021. Practices asked that we not distract them from patient care by announcing or starting something new at this point in time. In addition to the feedback that is reflected then in what the flexibilities that we put out last year, we also heard other feedback from our model participants that's helpful as we think about alternative payment models in the context of an extreme and uncontrollable circumstance more generally. For example, we heard about the importance of OCM in developing quality improvement habits that were critical in quickly and nimbly responding to COVID-19. And more broadly, we heard about the importance of value-based payment approaches in providing revenue stability when there are unexpected changes in patient and service volume. So to wrap things up, as we look ahead to the long-term implications of COVID-19 on cancer care, we at CMMI are thinking about their potential impact on a future model. For example, how will case mix change in the future due to delayed screenings today? And how long will those changes last? What will turn out to be permanent changes in care patterns, such as how often and which patients and how will patients need to be seen? And also, will telehealth and other flexibilities like hospital at home continue more broadly, and or should we consider providing them under a model? And finally, what does optimal high-value care look like in a non-COVID world? These are just some of the critical questions that we're looking to answer in the months ahead. So I'll pause there and I look forward to the discussion. Thank you.
Well, thank you very much, everyone, for those incredible talks. And it's a little bit like PTSD, I must say, going back 18 months and thinking about how frightening and uncertain everything was early on in the pandemic. Not that there still aren't frightening aspects that we're dealing with now, but you know, I think one of the lessons that we learned from all of you is that we were exceptionally agile in all aspects of medicine where we didn't have that as a tradition, that we learned from each other very, very quickly. We learned how to capitalize on the expertise of our colleagues everywhere, and we learned to keep the priorities of the patients and their needs foremost in our minds. And you know, I think that at the time, we were just trying to figure out how to get from Monday to Tuesday and Tuesday to Wednesday. but there were some very good things that came out of that, and us learning how to work together in ways we haven't before. So I'd like to start by putting all the panelists on the spot and asking you for, if there was one lesson that you learned during those early days of the pandemic, and what that lesson was and how you would use that lesson to shape cancer care going forward. So why don't we start with Rob, and maybe you can share your thoughts about that.
I think the thing that I learned right away was that structure matters. And that while we look at biology frequently and comorbid diseases, particularly at-risk populations, this really simply came down to structure. And I think that as I move through COVID, I am going to pay much more attention to the social determinants of health and how the policies are impacting those social determinants of health, and how, as a cancer center and other things, we can actually combat not only the biology, but some of these structural issues to keep people safe.
Great, thank you, Rob. And we'll go to Shelly now.
I would say that for patients, communication and clear communication in layman's terms is just so critically important, and it's such a huge challenge when they're facing both a cancer diagnosis and a pandemic like this. That was the thing that we heard so much from patients, even people not in treatment, people who are 10 years out from treatment, but they still needed, they could watch the news and see Dr. Fauci and see all the communication about the pandemic, but how did it apply to them as a cancer patient, and what did it mean for their risk levels? And I think that is a huge challenge, that, being able to put things in really clear terms so that all patients can understand is really challenging. We had a number of webinars. Dr. Otis Brawley joined us. He's excellent at putting things really in terms that patients can understand, and telling them what we know, what we don't know, what we think. And so I think those kinds of communications efforts are really, really important to help patients understand as they navigate through. Cancer is hard enough as it is without a pandemic on top of it. So the communication is just critically important.
Thanks, Shelly. I would say from my part that we learned that we can work together in ways that we hadn't worked together before. Very disparate organizations that sometimes barely acknowledged the other got together in virtual rooms and very, very quickly, in an agile way, helped to move the field forward at a time when we didn't have the luxury of time, if you will, that we had to move quickly, and we learned that we could move quickly. And that's not been the tradition of American medicine. And I hope we can learn from some of those factors and keep doing it for the benefit of our patients mostly, but for how we move the field forward. So Randy, do you want to make a couple of comments?
Thanks, Larry. So as Shelly said, cancer care is already incredibly complex. And then when you add the intersectionality of social determinants of health, and then resource scarcity, something most of us aren't used to considering, it really causes a tremendous amount of moral distress, which requires support for our physicians and teams, communication, and a really clear framework for what you're planning to do and how you're planning to support people going forward.
Great, thank you, Randy. Steve?
Yeah, I think one of the things that I really came away with as one of the big learning issues was how adaptable our staff were, to see how physicians, nurses, frontline staff workers could come together and take on roles that were unexpected. And I think what sort of the pandemic did is was sort of a crucible to help us identify new leaders that maybe we hadn't identified. And it was really a fantastic opportunity to see people working together in ways that many of us hadn't done before, all in the direction of supporting patients. So I think it's a great opportunity to be able to be more flexible and to continue that pathway forward.
Great, thank you. Karen?
The bad part about being this far in is, the things that are high on my mind have already been said. Communication, and also understanding that this kind of crisis unmasked deep, significant cancer disparities that became worse. during COVID. So anticipating those is really important. But if I have something to add to this discourse, I would say it's the importance of structure matters, but in a different way that Dr. Nguyen said, and that's organizational structure. So having real clarity on what the scope and span is for decision-making as you're reacting in real time is critical. You don't have time to sort that out in the middle of a pandemic.
Great, thank you. And last and certainly not least, Laura.
Yeah, thanks. Echoing Karen, I think a lot has already been said, and want to echo the importance of communication. It was really critical for us at CMMI to be able to hear directly from the front lines how folks were being affected. But I would say from my perspective, really trying to shift folks into value-based care and extend the reach of our alternative payment models. It's pretty important for us as we go forward at the Innovation Center and CMS more broadly, I think, to think about how we have flexibilities to be able to adjust our payment models when something like this occurs. In our voluntary models, we have participation agreements that have to get amended, and that takes a significant process to create those amendments. Similarly, when we have required participation, we have regulations that we have to go through that process, and all of that is time intensive. And so I think we'll have to think about strategies for trying to be able to respond more quickly. And one example of that is in our radiation oncology model. We just proposed a couple of weeks ago to add an extreme and uncontrollable circumstances policy that would allow us to be able to respond, in more like real time.
Great, thank you all. Those were very, very helpful comments. I want to start the question, and I'm going to start in a little bit of a hot topic, if you will. I think what we've all talked about is when we needed to, we came together as a unified group, made tough decisions that were really very coherent and reflective of us as a medical community. We're now faced with another one of those, and I'm going to ask Karen, in your former job as the leader of a cancer program in a very large health system, about the requirement for COVID vaccination. We did a lot of things quickly in the early stages of 2020 with the patient safety and our staff safety in mind. Things don't feel so urgent right now, but this is obviously an incredibly political and difficult topic.
Yeah, very difficult topic. So Jefferson at present did not elect to mandate the COVID vaccine, although it was discussed. It may, in fact, at Jefferson not be necessary to mandate because the uptake was so strong. So there was significant polling and surveying across all 33,000 employees prior to the time that the vaccines were actually available. There was deployment of information from Incident Command and our infectious disease group across the organization to try to encourage adherence and to reduce barriers for those who wanted to come and get the vaccine. So the uptake was so strong that I don't think that there was a field that mandating the vaccination was necessary, although certainly that could still be up for discussion.
Great, thank you, Karen.
The only other thing I would add to that is there were also a number of mechanisms to ensure that patients had access to the vaccine as much as possible. So very strongly encouraging and educating patients and caregivers toward that end.
Larry, what about your own system? Are you requiring vaccines? And Steve Pergam, what's going on in Seattle?
So
what are the systems doing?
At Penn, we are requiring vaccination for all people who work in the health system. And as you can imagine, it has been received with some mixed emotions, though I think the vast majority of us believe that it is true. And without trying to sound too preachy, I would say that if health systems, particularly academic, scientifically driven systems, can't take the lead in the necessity of getting widespread vaccination, who's going to? So I think we really need to stand up and make the statement that this is necessary for the public good. I believe in some degree of individuality, but we have a public good here, which we did respond to 18 months ago. I think we need to figure out how to do that now.
Dr. Schulman, I'm going to give you an amen.
I was just going to ask you, Rob. Thank you. And Steve Pergam?
Yeah, I would, as the infectious disease physician on this panel who works at a vaccine institute at a cancer center, I am 100% behind mandatory vaccines. I think what's challenging, of course, is that this does really put us in a position where we have to really get into the weeds with people who don't want to do this. We've done a lot to shift getting our numbers higher, has been discussed by Karen, that you're starting to see centers getting over 90%. But I think what we really want is our patients to enter areas that are protected. And I would echo what Dr. Schulman said, but I want to really sort of emphasize that cancer centers, beyond just academic centers, should be the highest rates of vaccine of anyone, because our patients are the ones who have the largest burden. And I think, if we can make that decision and move that forward, I think it's very strong. And I would sort of also say it's not just COVID. We need to move beyond COVID. We need to look at things like measles and other important vaccines, because these are all ones that can have major impacts. And so as Dr. Knudsen and Dr. Schulman said, I think it's really important. And I echo Dr. Wynn's comment. I think that I got a Yahoo for what Penn's doing at the moment.
Larry, can I ask the group another question? So again, we're thinking back 18 months ago, and I at least am thinking about all the attention we were paying to the modeling. A couple of you mentioned the IHME, the Johns Hopkins, all these kind of models that were going on, which didn't always say the same thing. And we made a lot of decisions based off of them. I think in some cases, certainly in our state, Steve, I recall that we stood up a whole field hospital based on models, which thankfully was never needed. But other places were not so lucky. So how do we think about this when we face whatever the next crisis is going to be? Of course, there will be other models going on, and how did we use them, and how would we think about how to refine that going forward? Open to anybody who wants to comment. Do you want to start, Steve?
Yeah, I mean, I think, the challenge was models are always based on the data that goes into them. And so depending on what the different modeling structures were, there were sort of benefits and negatives. I think we all went into that. I think you need to go into that with open eyes. I sort of looked at it from the perspective that it was better to sort of over prepare than to under prepare. And I think what a lot of those models did is they provided us worst case scenarios. And they did, I think, really do a good job of predicting when peaks would happen. I just think the peaks were different than we expected. So as an example, if you remember, Dr. Davidson, that we prepared for oncologists to be ready to take care of COVID patients for a while with a surge, but that surge never really materialized. And so I think that was important to have that opportunity to prepare for worst case scenarios. And I think that's where the modeling was probably the most beneficial in my view. But I think you just have to go into the limitations of what they bring.
I would echo what Steve was saying, which is I think we also over-prepared. None of us really knew what the trajectory was going to be. None of us knew where this was really going. But it's always comforting to over-prepare rather than under-prepare. And so many of the things that we put in place as a contingency, we ended up not having to use. And that was comforting, because you'd hate to be in the opposite position.
I would very much agree with that. I know Dr. Schulman's in our area, we all got hit very hard in Philadelphia. We had to engage surge planning many times. We had mobile morgues. It was not as bad as it could have been according to the modeling, but having that modeling to understand what the worst looked like was something that we discussed in our incident calls, and really was very helpful, I would say, even if we knew at the time that it was an estimate, and you can accept that and still plan.
So I wanted to ask Randy and Karen, both of you talked about your surrounding networks of cancer providers and how you communicated and how you work together. And my question to you, both of you, maybe starting with Randy, is, are those communications with, frankly, people who are in your community, who are your competitors, where you work together, are you still doing that? Are you going to still do that going forward? And Karen, some of the things you put in place for your system, are they still in place?
Larry, thanks for the question. Our competitors have now become among my closest collaborators, friends and associates. We were having a weekly conference call every Tuesday morning at 7 a.m. And I don't know how many months later this is now. We're still doing it every other Tuesday, including tomorrow morning at 7 a.m. We have an agenda. We're going to be reviewing the July 21st New England Journal paper on Delta and vaccines. We try to send out pre-reads so that we're all, understanding the same information. And we are all, I think, as Dr. Knudsen referred to, making decisions in real time together, but we're stronger together. And taking a word out of Rob Wynn's title from his talk, trust. We've built that trust. We're going to maintain that trust, and we're going to continue with our open lines of communication. We really feel responsible for the community together, and we are in it together. Thank you.
Yeah, and for us, cancer care is distributed across a 14 hospital system, but much of it clustered around these 4 advanced care hubs for cancer that we stood up. Now, those are all us. Those are all owned and operated, Jefferson. But it's the case that even within our own system, having that daily touch point of being able to talk to each other on Slack, but also when we were truly in the peaks, and everyday touch point for leadership really helped us, because there were times when there were variances in opinion, especially about putting in a variety of different safety protocols, or how we would handle things like providers changing clothes before they went home, or things that none of us had ever had to deal with before. That allowed us to have a single point of view and a single policy quickly developed across the system. When it came to connecting with the community network, that was something that was so that was an escalation of a process we had. When it came to connecting with the community networks, many of those were net new relationships that got built, that trust that was just alluded to that got built, where we would get the call to say, our nurses we have too many nurses that are COVID positive. Can you help us with our radiochemotherapy patients for this period of time? And so those led to great relationships. There's not as much as I think there could and should be room for a set schedule for that touch point. Just the ability to help each other in those situations led to new relationships that I hope and think will be longstanding. But it was not quite as formal as what was just discussed in terms of a weekly call. I think that's a terrific idea.
So maybe the message to the audience is, hold on to those relationships. There are good aspects to them, and we need to keep them up.
You're right. I think, Larry, that collaboration was a key theme amongst many of the discussions today. I wanted to move us to a different direction for a moment, and I'm basing this off of a question that we got from Kathleen Wiley from the Oncology Nursing Society. She asked pretty specifically about what the training requirements that were set for clinicians engaging in telehealth. Now, we're going to talk about that a lot in another session, but I think it does bring up for me that I feel like there are 3 new technologies that we brought on board really rapidly. First was telehealth, and Kathleen, I'll answer this question for me, which is that I took an online course and I went from uncredentialed to practicing telehealth in 10 days. And never, ever, ever in my entire career did I think that would happen. We'll learn a lot more about this later. But the second thing was we brought on board testing, right? COVID testing in a very short period of time. And then, of course, most recently, many of us have been involved in COVID vaccination strategies, particularly for our cancer patients. So I'm wondering whether there are lessons that we've learned about how rapidly we pick these things up and how we were able to educate our workforce, our staff, our physicians about how to do this stuff in a way that made it effective. Anybody want to comment on that?
I have to say, I was just surprised. I've come up through a system through lots of state universities and other universities, and we were always told about the bureaucracies and why things had to happen. This is the most interesting thing. It's like when there's an emergency and a sense of urgency, finally, you can get to common sense and practicality. So for the first time, we were making rules that were practical. And instead of saying, well, I had to do this to check this box and this box, it was, we need to educate these people to get them ready to do X, Y, and Z. Some of our field people, some of our navigators and then things like that, we had a chorus and we ran with it. But the cool part was, because of the virtual tool, we were always able to check in more frequently than we had in the past. So I hope that this is something that actually will stick with us as we're moving through COVID and into the future, of being able to use the technologies that we have to kind of more frequent check-ins to make sure that people are getting it. But the more practical aspects of not 30 pages or 45 pages or 60 pages to do something that just makes common sense. That was something that was brilliant to me during this whole thing about how many of us were able to just really get to the core issues and then work with people. So that was, hopefully something that my system will continue to do. And also included clinical trials, by the way. For the first time, we were able to, not as a result of cancer patients, and this COVID, we're now better able to get through our IRBs and everything else around our clinical trials as well. So, but that's a topic for another day.
So the one thing I would add to that, and then we have a question from Dr. Shilsky, who is all of our boss for this workshop, is that, it wasn't like black and white. It wasn't that we didn't know how to do telemedicine on Monday and Tuesday we knew how to do telemedicine. We were learning as we went, at least at Penn. And we learned in part because of what others have said. Every day we got multiple communications from our leadership, really communicating what we learned yesterday and how we should approach today. And it wasn't always predictable. So we learned along the way because we had the processes in place to do that, which we usually don't do. So Nancy, I don't know if you want to ask Dr. Shilsey's question or.
I do in a minute, but actually before I do that, I want to ask Laura. Laura, I realize that you're speaking for CMS today and you can't say everything, but one of the other changes for all of us, of course, was that CMS was so flexible, as you pointed out, that it too saw what was going out there and made it possible for people to do what they needed to do and to not have concerns about regulatory breaks on that. So I guess the question is, how can CMS retain that? And that does go into Rich Shilsky's question for all of us, which is that, why don't we have the same sense of urgency about cancer care in this country when we still have 600,000 people who die from cancer every year, and whether that can inform many of our processes. Laura.
Yeah, thanks, Nancy. I will perhaps leave the urgency question for the rest of the panelists. I personally feel great urgency around cancer care. In terms of your question, though, about CMS and flexibilities and the importance of those, I think it's important to recognize that a lot of the regulations in place at CMS are really about providing safeguards to ensure that patient care is high quality. And so I think we have to find the right balance between having those safeguards in place and then having flexibility. I thought Shelly's results earlier in the presentations were very interesting around telehealth, because we certainly at CMMI have heard from folks about wanting flexibility for telehealth in the future. And if CMS doesn't keep it broadly, that we at CMMI should do it within payment models. But I think, some of the results that we hear from patients is pretty interesting in terms of wanting to have some return to in-person care and preferring inpatient care. And obviously there's a diversity of viewpoints there. So, I think as we look to the future, making sure that we understand how patients want to receive their care and then trying to figure out the right way to both protect patients and then give flexibility to allow it to happen in a high quality way. We're going to try to strike that balance. I'm not sure it's a very hard thing to do, but hearing from you all and from patient groups is critical to that.
The one thing I would add to that, Laura, I think we've all often thought of ourselves as the medical providers and the payers, and we're combatants on the field, and arm wrestling with each other. But I really felt like we're all together, we're all marching together, and the bottom line was the same, which is we wanted to figure out how to make this work for the patients and the providers in this circumstance. And personally, I want to thank you and your colleagues for really, all the things that you did and did so quickly. And I'd love to see that collaboration, between us continue. I think this is a great opportunity to see that go on. Karen, you have something? You have your hand up?
I was just saying amen to what you just said.
And Laura, I guess the hope would be that, we wouldn't just be like a rubber band and snap back to where we were before, that we'd be able to think about the things that really did make sense, that do protect patient safety, but make everybody's lives easier. And so I hope that our regulatory agencies like your own, our state regulatory agencies, all the groups that we work with are going to try to keep that in mind and not just simply revert to form. Shelly, I think that one of the things that was brought up was that the patient perspective is so important here. And I don't know how you react to some of the parts of this last part of the discussion.
Well, I would say, first of all, hearing that the collaboration to quickly make policy decisions, and then collaboration among, cancer centers in an area is heartening from a patient perspective, because while I understand that you are competitors, from a patient perspective, that's not how patients think about it, and to the extent that competition is in any way detrimental to their care, that's not ideal. So hearing that there's collaboration and the way that so many silos were broken down during the pandemic to make quick decisions is really helpful. So I do think it's really important to think about how do we continue that going forward. And I just want to say too, on the telehealth, that what we heard from patients, I was a little surprised, to be honest, at how we thought about it in terms of, I think about the burden on cancer patients of how many appointments they have to go to with different physicians. And I've thought about the fact that we want to make sure that telehealth is still an option to them if they want it going forward, and worrying about, if we do go back if we don't have the payment policies that allow for telehealth to continue, will it not be an option to them? But clearly, you saw from our results, they want to go back in person for a lot of these visits. So I think we really have to think about that, and it's definitely, it varies, because some patients are happy with telehealth for more types of visits. But it was only a few where a majority of the patients that we surveyed said that they would prefer telehealth. So I think we have to figure out how do we make it accessible to patients who want it, but also have that option for in-person, because I do think, it's also, in addition to the burden on patients of the many visits they have, it's also, they need that in-person connection to feel like they're getting the best care that they need going through a stressful time in their life. So I think, it is going to have to be an individual decision as to which is better for that patient and for the type of visit, I think. And trying to minimize burden on them while also maximizing the quality of their care.
I just want to give a plug for session 3, where I'm hoping we're really going to pick up on these themes and go over it in great detail, and also talk about the impact that telehealth has had on increasing access to cancer care.
So I think that last point is going to be critical, and we're just about out of time anyway, but, at least in my own example, you mentioned, Shelly, that for new patient visits, in-person visits were felt to be more valuable. And I think ideally that's the case. So on the other hand, we saw a lot of patients for their initial visit by telemedicine who did not live very locally. And they wanted to know whether, frankly, it was worth coming in, driving all the way to Philadelphia for an appointment, and whether we had something to offer them that they weren't getting closer to home. And so there's so many different shades of this. And I'm sure in the telehealth session, we're going to get into this, but, Laura, listen closely to this, because we're counting on you to go along with us, to march with us, and what we think is really the best for all of our patients. Not to put you on the spot.
Thanks, Larry. I'm here and always available to folks, so thank you.
As we close our session, we started with Rob Wynn, who gave our keynote address. And Rob, I wonder if you have any closing comments for this session, which was meant to set the tone for the remainder of the workshop.
Yeah, I thank you for that. I think the two things that I really love hearing about all the talks about teamwork, one team, one fight, working together works. The other thing is communication. In fact, we are transitioning at VCU Massey from communicating for patients or communicating to our communities to communicating with them, and having much more of their voices about what what sticks, what resonates in their message, as opposed to just sort of having our development people or our communications people decide. And I think that messaging around COVID has really been very helpful in reaching particularly rural and at-risk communities. And we're going to be using that more forward. And then the third one, I know not to be Pollyannish about it, is that, and not to pat ourselves on the back about it, because I think that we certainly could do better, but actually we can, as a group, do so much more when we get rid of the ridiculousness sometimes that keeps us apart, the silos. When we ourselves decide to actually roll up our sleeves and get busy, we can do great things. So again, COVID is not great. And again, one of the things we have now is not a push just against the vaccine, but a push against minds and hearts, right? So this issue about building trust, I think Theodore Roosevelt once sort of said it, the reality is people don't really care how much you know until they know that you care. I do think that that is one of the things that we as health systems are going to have to, in cancer centers, figure out how to do a little bit better job on getting our people to understand that with all the mis and disinformation, that we are a trusted source and we'll have to earn that respect. And so that is not easy, but I'm up to the challenges. I think we all are.
Well, thank you all. This has really been a terrific way to start this workshop. And over the next day, today and tomorrow, we're going to solve all the problems of the path forward for cancer care in the U.S. And this has been a terrific start. So thank you all to our speakers and panelists. And I think we now have a break until 12:50 when we'll reconvene for session 2. Thank you.